Hello, Linda. Hello, how are you? I'm going to save my bandwidth.
Doing okay.
Oh, good. I'll come back on before we start. Okay. Welcome, everyone. I want to welcome you to ACMI's stakeholders meeting. And this month, we're going to talk about assertive community treatment teams. We're very fortunate to have several presenters, and we'll be able to hear about the programs from both Valleywise and both Copa Health, and then Mercy Care is going to join, and Blythe Fitzgerald is going to talk to us about what the REBA is looking for when they look to expand and provide services, ACT services. What are the things they're looking for? I am going to turn my video off because I have low bandwidth here, but let me go ahead and introduce the speakers, and then Dr. Darling can take over. And Dr. Darling, if you want to control your slides, that's fine. Okay. So to begin with, Dr. Darling is the current medical director and psychiatrist for Valleywise Health Assertive Community Treatment Program. She's been in the role since graduating from psychiatric residency in 2017. She's core faculty with Creighton University and faculty in the Departments of Psychiatry at University of Arizona College of Medicine in Phoenix, Mayo Clinic College of Medicine and Science in Phoenix, Creighton University College of Medicine. Dr. Darling completed her undergrad in psychology at ASU in 2004. She then worked as a case manager for the outpatient FMI system in Maricopa County before attending medical school at Midwestern. She completed her psychiatry residency training at Maricopa Integrated Health Systems in 2017. And during her residency, she served as a chief resident for two years and was the Arizona Psychiatric Resident of the Year in 2017. She's board certified in both psychiatry and neurology with a primary focus on treating refractory seriously mental illness. In addition to her clinical work, she trains Creighton Alliance psychiatric residents. She teaches 2 didactic courses for Creighton residents, covers community services for the residents, advanced pharmacology. I messed that one up. She's involved in mentoring the students as well. So that's Dr. Darling, who you'll hear from first. And then next is Dr. Belamonte, who's also a board certified psychiatrist. She is the assistant medical director for ACT services and chief psychiatrist for the Metro Clinic of Copa Health. She is a product of the University of Virginia's health system at Charlottesville, Virginia, where she attended psychiatric medicine with a subspecialty and fellowship training in geriatric psychiatry. She went on to serve a full spectrum of psychiatric practice in the rural, underserved areas of Virginia for 3 years. Challenging as it was, the experience galvanized her knowledge and acumen in clinical work and deepened her passion to provide the best services to those struggling with mental illness. The passion took her to Phoenix, where she saw an opportunity to provide services in an environment where team-based approach to care is alive. She has served under multiple REBAs in Maricopa County since 2005 in various capacities, but mostly as the chief psychiatrist of clinic and ACT team. She was the first medical director of People of Color Network. She is a dedicated psychiatrist who has extensive experience in complex pharmacological and complicated social determinants of health issues. And then Blythe Fitzgerald will be speaking. She is a chief clinical officer at Mercy Care and responsible for clinical program development, including adult and children systems of care and central region behavioral health crisis system. She oversees many services from Mercy Care, including integrated care, OIFA, grant services, cultural diversity, tribal affairs, and direct initiatives and strategies and programs to address the social determinants of health. She also oversees the coordination of care with stakeholders, such as Department of Economic Security, Arizona Department of Justice, and works closely with system advocates. So with that, let me turn it over to Dr. Darling, and I will then allow you to go ahead and share. Welcome, Dr. Darling.
Sorry, brief technical difficulties, but I think we are there. Thank you for the very kind introduction. I appreciate that. Let me switch us into presenter. All right, is everybody able to see the slides?
Yes.
Okay, perfect. So I'm going to start with a story, call it the story of Jane. Jane is a divorced woman in her mid-40s with a diagnosis of schizoaffective disorder, bipolar type, and amphetamine use disorder. She started with our ACT program back in May of 2018 while actively hospitalized after being in jail for 3 months. She was discharged back to jail, then released after a couple of weeks to homelessness. Let me close my email so that doesn't happen again. She would go back and forth between staying on the streets, various different shelters, sober living placements, jails, hospitals, but wouldn't stay in any one place very long. She was often on what we call outreach on our team, where the team makes various attempts throughout the week to locate missing people by looking at their last known or highly frequented locations, calling hospitals, jails, family, even the morgue, to attempt to locate them. She would frequently show up at her previous clinic or could be found staying at different locations between their clinic and ours. And this cycle continued for 6 months, but was eventually ended when Jane was housed in an independent apartment subsidized in December of 2018. So today we're going to go over a really brief history of assertive community treatment, discuss some of the research behind assertive community treatment, as well as review the SAMHSA ACT guidelines, and then talk a little bit about specifics to the Valleywise ACT program, which I'll sprinkle in a little bit of as we go as well. When we look at the history of ACT, ACT really started in the early 1970s as the deinstitutionalization movements began throughout the country. It started at the Mendota Mental Health Institute in Madison, Wisconsin by Drs. Arnold Marks, Leonard Stein, and Mary Ann Test. What they noticed is that as patients were being discharged from inpatient stays, which were often much lengthier in that time, in stable condition, they would get sent out to traditional outpatient settings and would quickly decompensate, leading to rehospitalization. These patients were often described as non-compliant or treatment resistant or even unmotivated. And what Drs. Mark, Stein, and Test discovered in really evaluating this revolving door of hospitalizations is that it wasn't necessarily a patient problem, but a systemic problem where the patient's needs were going unmet in the community mental health system as it was set up at the time. They had first started by implementing programs in the hospital to attempt to teach patients life skills, but they found that as they discharged them back to treatment as is, outpatient, that folks wouldn't be able to use those skills in the environments they needed to use them, even though they could do them in the hospital. So that's when the idea was born that we need to teach folks the skills they need to live independently and within the community in vivo, in the setting that they're going to be in order for them to successfully be able to adapt and be in the outpatient setting. And that is when ACT was born. It was developed out of the idea of having a service delivery model of a team that provides a combination of services within that team at individualized frequency, intensity, and length for each patient and available to the patients 24 hours a day. Because ACT started in the 1970s, we have 50 years worth of research on it, which is really helpful and has been helpful over the years to figure out what works, what doesn't. A lot of things have been tried. And what they have found is that when ACT is followed, which we'll talk about the fidelity coming up here, to the key components that have been shown to be helpful that leads to a significant reduction in overall hospitalizations, improved stability in housing, improved family and patient satisfaction, a reduction in levels of substance use, and a reduction in cost for the entire system. I think it's important to note that as we look at the main components of what can be achieved with ACT, that we aren't really talking about reduction or elimination in symptoms, abstinence from substances, but instead focusing on an improvement in functioning. And I think that's really an important theme as we look at what ACT team's goals are. The research has been very consistent over the years with dozens and dozens of papers and meta-analyses looking at ACT that have shown that in order for an ACT team to be successful, it has to follow the core principles of ACT and implement all of the ACT components. There have been many organizations over the years that have attempted to sort of pick and choose which elements they think are most important and to include in their program. And those are the organizations that have typically not had outcomes comparable to those in the literature that have followed ACT principles wholeheartedly. I think one of the areas that this tends to come up a lot is, at least for us, is who we take on to the ACT teams. And we're going to go over a little bit on the next slide what the admission criteria is for ACT. But frequently, that's one of the questions we get at Valleywise the most is, why don't you think this patient would benefit, or this person, or, so on. And there are very specific criteria for who benefits from ACT. And it's important that those criteria be met, or your patient's not going to experience the expected outcomes. We're going to look a little bit at what the principles of ACT are. I know there's a lot of words on this slide, and I was trying to come up with a good way to reduce it, but there's not one. So I'm gonna not read it all to you, but try to individualize it a little bit to what we do at Valleywise. The services are targeted to a specific group of individuals with serious mental illness, and we're going to go through that admission criteria like I talked about. It's not brokered case management, which is more traditional for our supportive level of care and connected level of care treatment teams in the SMI system, where each person's assigned a case manager, and then whatever services they're looking for, that case manager would then refer them out for the different services. Here on ACT, the goal is that the ACT team provides all of the different services. They're responsible for all of the different treatment interventions that are available for the patients. Team members share the responsibility for the individuals served by the team. So for example, on our team, all of our case managers, we call them specialists here, interact with all of our different members or patients. They all have different specialties. And so depending on what treatment goals the patient has, different members of the team will be meeting with that person to work towards their goals. There's not one person who is solely responsible for any one person on the team. This is really helpful for a variety of reasons. One, we have different specialists who are able to intervene and help on those specialties. The other is that there is much less disruption in care when somebody goes on vacation, when somebody's out sick, when somebody leaves a job. And so that can be really, really helpful. The staff to consumer or patient ratio is small, approximately 1 to 10, and we meet that goal readily here at Valleywise. The range of treatment services is comprehensive and flexible. We're always adjusting what we're working on with people based on what goals they want to be achieving and what is outlined in their treatment plan. Interventions are carried out at the location. So we had talked about that previously. They tried that in Wisconsin to do the interventions in the hospital and hope that it translated. And what it turned out was that it didn't really translate. It's better to teach somebody how to do something in vivo. So one of the examples we always use is teaching someone how to do their laundry. It's really hard for me to teach somebody how to do their laundry sitting across a desk from me in my office, but it's really easy for my independent living skills specialist to take them to the store, show them which products to purchase, take them to the laundromat or to the laundry room at their apartment building, whatever it may be, and go through the process with them and show them all along the way how to complete that task. The patient is much more likely to remember that and take that with them. There's no arbitrary time limit on receiving services, so we consider ourselves a time unlimited service. It's very customized based on the patient's needs. Treatment and support services are individualized. Everybody goes through a treatment planning meeting. We revise treatment plans frequently, and we implement services that the patient is wanting based on their goals. Services are available 24-hour basis. So the way our team specifically works is we have staff that are working 7 days a week from 7 a.m. to 7 p.m. That is their active working schedule. And then we have 2 staff that are on call 24 hours a day. And that rotates every week. We have 2 different staff taking on call. That means that if somebody calls the crisis hotline, they'll reroute them to our crisis or on-call person. And most of our patients know our crisis or on-call numbers, and they would go ahead and call them directly. If somebody just needs to talk, we can talk them through a crisis or an emergency on the phone. Or if somebody is needing in-person intervention, we can go out 24 hours a day to meet them in the community where that crisis is taking place. It's an extraordinarily helpful piece of ACT because we know our people. And a lot of times when you have unknown crisis workers, they're doing the best they can. They're preventing a crisis situation, but they don't know the person very well. And so we are able with that relationship to really de-escalate a situation and prevent hospitalization. The team is assertive in engaging individuals in treatment and monitoring their progress. We are out in the community all the time. It's always funny when anybody ever comes here for a tour of our clinic. There's almost never anybody here. It's me, sometimes the nurses, our front desk staff, and sometimes not me. I go out and I do home visits a couple days a week as well. And then I'll show them all of our specialists or our case managers room, and there's maybe one person here because we're out in the field. We're out meeting people where they are to work on their goals. So SAMHSA has gotten very involved, as they have in a number of other evidence-based practices in mental health, and compiled all of the data for us, which has been super helpful. They created a kit on their website that you can get that basically tells you everything you need to know about ACT and how to set up an ACT team and how to be high fidelity, meaning keeping in line with the practices that have been found to be most effective for folks. They have all the research all put together in one tidy little kit. So before I started working on this team about 6 years ago, I spent lots of time taking a look at that. And if you talk to any of the residents who've had the privilege of training with me, they get to have that book with all my highlights and annotations handed to them on day one of something they need to achieve and read while they're here to learn. They've laid out the necessary components of ACT that have been determined to be which pieces of the model are the most linked to improved outcomes for patients. The teams that maintain fidelity to the SAMHSA ACT model the closest are the teams that are most likely to have outcomes as expected. All right. They even lay out a development process. We're not going to go through all of this today. Ooh, I think, is there a question, Lori?
Back on your last slide, you talked about a differentiation of which components were necessary to achieve the high level of
Yes.
improved outcomes. Which ones are those?
There are so many of them. I didn't actually include them all, but off the top of my head, there are a couple of different things. The biggest is the intensity. And so time intensity, the way that's measured is how much time we're spending with each individual. So they get down to the nitty gritty of that. Our goal is to spend 120 minutes per week with each patient or member on our team, providing services to them. That may seem like either a large number or an arbitrary number, but basically when you get 50 years worth of data together, they're able to find these averages. So the goal is an average of 120 minutes over 4 different visits with a patient throughout the week in order to provide that care. Another example of some of the data points on there are things like substance use. So for folks with co-occurring substance use disorders, the goal is a minimum of at least 25 minutes of individualized substance use counseling and at least 1 hour of group substance use counseling per week. And so those are the kind of data points that are looked at. We'll talk a little bit at the end about how we're evaluated, and they will look at all of that during our audits and making sure that we're meeting all of that, all of those goals for people. But there's lots of other criteria, having certain members on the team, having that consumer to staff ratio of 10:1, having a full-time dedicated psychiatrist. So that's my big metric on this, that I'm full-time, my full clinical time is spent here in ACT, having 2 full-time nurses, things like that. And if we have time, and if I don't know if Blythe may have the actual tool that they use as part of her presentation. If she doesn't, I'm happy to pull up the tool so you all can.
I don't, but based on this conversation, so I just joined, but I can share the link in the chat because it has what you just shared. It's like the toolkit, the evaluating, and that is exactly what Witchy utilizes when they complete their reviews and what the scores are posted on. So I'll put that in the chat.
I didn't include ours because they have our data, although I did include some of our final data at the end of the presentation. Does that answer your question, Lori?
Yes, thank you. As you spoke, I was thinking of the Witchy reports and the nature of services versus the number. Do you have housing? Do you have employment? Do you have a psychiatrist? Do you have a nurse? So as you talked, it brought back to mind.
Yes, it's all of those. And there's dozens of them that they really get into the nitty gritty of.
Thank you.
Sure. Okay. So as part of the kit, they offer all this guidance for the development process that we did follow. We opened our ACT team back in October of 2017, and we went through all of these phases as part of our development. I am not going to go through all of them in detail, just the ones that I think from my experience, people have the most questions about and that are the most interesting in my opinion. So the admission criteria, this is something I get asked about all the time. So one of the things that I wanted to spend a few minutes talking about. This is the SAMHSA ACT admission criteria that they include in their development process. Mercy Care did an excellent job going through all of this and creating our screening tool based on that. So I'm going to show you all of that. So ACT is essentially designed for the 20 to 40% of serious mental illness patients who have the most dysfunction in their daily living and tend to have the highest utilizers of the system. The impairments that people tend to experience that benefit from ACT are having safe living environments, being able to take care of their homes, maintain employment, and practical ADLs. They are typically patients who are diagnosed with schizophrenia or other psychotic disorders, and sometimes bipolar disorder, as these diagnoses tend to lead to longer-term psychiatric disability for folks. We give priority to folks who have been hospitalized, high utilizers of psychiatric hospitalization. So typically we're looking at 2 or more hospitalizations in a year, intractable, severe major symptoms, co-occurring substance use disorders, high risk criminal justice. So people who are constantly getting involved with the legal system, regular arrests, or just having police involved frequently, homelessness or at risk of homelessness, basically living in a hospital or a residential, and the only way that they could safely be discharged from those types of settings would be in order if they had an ACT team to provide that higher level of care. And then people who are not able to participate in traditional office-based services. So one of the things you heard me talk about earlier is I do home visits, our nurses do home visits, our specialists do home visits. We are all out in the community. So I have, probably a handful of folks on our team who've never been to this clinic. They've never seen the inside of our clinic ever. I've always seen them at home. Our nurse goes to their home to do their blood draws, do injections and things like that, because coming to the office is just not functional for them at the time. Patients should not be excluded from ACT due to the severity of their symptoms, their lack of adherence or response to traditional treatment, or for the need for hospitalization in a crisis situation. While one of our main goals is to reduce hospitalizations, particularly for folks who are being hospitalized regularly, we also understand that acute hospitalization does happen and that we will help facilitate that when it does. There are also people who ACT has been shown not to be terribly helpful. Those groups of folks include people with a primary personality disorder, people with primary intellectual disabilities or developmental delays, people with primary substance use disorders and not a primary psychotic disorder or schizophrenia. ACT is not intended to be used in conjunction with staffed treatment facilities. So this happens frequently. We will get a referral at the same time from a hospital that somebody's also being referred for a behavioral health residential facility or a flex care or a staff CLP. While there are exceptions to this, and sometimes folks do need both services, we do want to typically try one avenue or the other first for people. All right. So, like I said, Mercy Care created their admission criteria based specifically on all of the things that we talked about. So I just included a copy of the screening tool. It's what's used by every single ACT team out there in Maricopa County. It's what we're required to use. And if you go through and read it, which I'm not going to read it all to you, it says exactly what we just talked about. It's all of those different high priority things and the functional impairments. It has the diagnosis. It has all of the different functional impairments. One of the other things that we always do is a comprehensive record review. So I sit and read. That's what I spent an hour this morning doing, reading thousands of pages of medical records for folks who've been referred for our clinic and talking with the current providers at the clinics where they're receiving care, or the inpatient doctors or nurse practitioners where they are currently, to get a case presentation, get a better understanding of what's been going on for this person and why they're recommending ACT, what it is that they're hoping to see. A lot of times people don't really understand what ACT is. I think that's why we were asked to talk today, to help educate people and provide broader understanding of what ACT is. And so sometimes we will get referrals that don't make a lot of sense or aren't appropriate for that person. And we'll try to provide ideas and guidance for those teams of what might be helpful. And sometimes referrals are great and we'll get people onboarded as quickly as possible. So what we do when we get a referral is complete this screening tool with each person. If they have a guardian or an advocate or their outpatient team, will include all of them in the screening process. And then as a team, make a decision whether somebody meets criteria for ACT. All right. Discharge criteria. So there's been 2 major studies that have evaluated discharge from ACT, and both of them found exactly the same thing. People should not be transferred from ACT for any arbitrary reason. It shouldn't be time limited. It shouldn't be, there needs to be very individualized determination of why somebody would be graduating from ACT. They found that when they attempted to transfer patients back to standard care after 1 year, that there were substantial setbacks, and people often were rehospitalized or having to be re-referred for ACT. The other study really looked at how the step-down process should take place, and what they found was that the most successful step-down or transition process happens when there's an overlap for a period of time as somebody transitions from ACT down. In our terms, in Maricopa County, to that supportive level of care is typically where we would step them down. This can be a slow coordinated transfer, can be difficult sometimes in the Maricopa County system, especially if we're transitioning from one agency to another, because it does have to sort of be end date, start date. At Valleywise, we do offer all 3 levels of care between ACT, supportive, and connective. So if we're able to graduate somebody to our own supportive team, we will work collaboratively with them to help ensure that the smoothest transition is possible. All right, so how do we measure our success? Well, not by graduation rates, right? We just talked about that. We don't really, our goal isn't necessarily getting people off the team as fast as possible. It's making sure that people have all of their needs met. They've met all of their goals for being on ACT before we go ahead and graduate them from our program. We have lots of different ways we measure our outcome. We look at outcome data, including hospitalizations, incarcerations, employment, housing, all kinds of data that Mercy Care likes to ask from us every month, and that even though they stopped asking for some of it, we still keep track of it because it's important information. We keep track of our face-to-face is the big term we use. So how often we're seeing people, how many minutes we're spending with them when we see them, what kind of services we're providing with them. We keep all of that data up to date regularly. We also have more formal audits. So Access utilizes WICHE, which we talked a little bit about, to complete independent audits for all of the ACT teams in Maricopa County on a routine basis. And they use the DAX, which is the Dartmouth Assessment Community Treatment Scale, which meets the SAMHSA criteria that we've looked at to a T. It really hones in on all of those things, and it's dozens of different measures, which we talked about some of those a few minutes ago. And we get rated. We get rated from 0 to 5, depending on how well we're doing on all of those things. And as we look at Valleywise's scores and data, I'll talk a little bit about how that works out. And then subjectively, how do people perceive they're doing? More than anything, it's important that the patients feel like they're getting what they're wanting out of this. They're having an opportunity to reach their goals or work on the goals that they were looking to reach. If we take a look back at our story that we started with Jane from the beginning of our talk, she remains in independent living, although not the same apartment that we put her in 2018, but only her second one since that time, which is pretty good. She has not been psychiatrically hospitalized since 2019. Before ACT, Jane had minimal contact with her extended family. If we asked Jane if her treatment has been successful in light of many ongoing current challenges that she continues to face, she would tell you yes. She would explain to you that success for her is measured by her improved relationship with her family. For the first time in years, Jane has been invited to birthdays, to Christmas, to all the family engagements and holidays. She has been able to build a relationship with her children, her grandchildren, her parents, and her siblings. And even her sister is now her next door neighbor, and they are best friends. She would tell you that being housed for 5 years continuously is not something she dreamed could have happened 6 years ago. She is so proud of how she's decorated her apartment and made it truly her home. She is known in her apartment complex now as the person who takes care of everybody. So if anybody's hungry, she's making them a meal. If anybody needs soap, she's getting it for them. She would not probably tell you that she continues to experience severe symptoms of psychosis that are interfering with her daily. She would not tell you that she continues to experience these symptoms despite very aggressive medication management. She probably wouldn't tell you she still requires medication observation, and we go to her home every single day to observe her taking her medication, and that she remains on court order year after year because without it, she would not continue her medication. She would probably not tell you that she also continues to use meth occasionally, and sometimes those days can get a little bit wild. But what Jane, her family, and her team would tell you is that she has experienced success that is meaningful for her and defined in her terms, not mine. I chose to talk about Jane specifically because many people who would meet her now would still describe her as sick in the eyes of the system and those who don't really understand the debilitation that can occur with a chronic psychiatric disorder. I chose to talk about her because I think it's important to learn that complete remission of symptoms is not the only measure of success. I chose to talk about her because she highlights the spectrum of the different services that ACT is able to implement on so many different levels. I chose to talk about her because she shows that recovery is a process that can take time and years for many people. When I first meet people at our initial intake, one of the things that I often say to them is ACT is a marathon and not a sprint. It's taken people a lot of time and a lot of effort to get to us here on ACT. And we aren't going to solve problems overnight. We are about putting in the time and going slowly with people at the rate they need to go to get improvement in their functioning in a way that is meaningful to them. So when we talk about Valleywise specifically, this is the makeup of our current team. So we have a psychiatrist, that's me. I have been our psychiatrist and medical director for coming up on 6 years at the end of this month. We have a clinical coordinator who's also our primary therapist on our team. And she's, if you're not familiar with that term, that's basically our team leader. We have 2 registered nurses. We have a medical assistant, a program assistant, a registrar, and a department assistant. I would say we're very lucky at Valleywise. I have tons of support staff up front and in our medical side of things. And then on the right, we look at all of our different specialists. People may call them case managers or specialists. We call them specialists because they have specialty expertise in various things. We have a rehab specialist who's committed to working with folks to get them connected into the community and increase socialization, an employment specialist who also works with folks on education, a peer support specialist, 2 substance abuse specialists who provide that substance abuse counseling we were talking about earlier, a housing specialist, an independent living skills specialist, and then our generalist team specialist. And on our team, that's our most experienced team specialist. So all of these folks are cross-trained in all of each other's specialties and can help, provide coverage. And if you're the peer support specialist, but someone wants to talk to you about their substance use, they're not going to say, hang on, I'll get you the substance use counselor. They're going to talk with them about that and work with them through that. So how do we do? How do we add up? I just laid it all out there. This is all public information too, so you can see all of our audits online. These are all of our audit scores that we've had since our inception in 2016. The goal for high fidelity is over 4. Everything is measured on a 0 to 5 scale, and then it's averaged out through all of those different metrics that we talked about. So as you can see, we have met high fidelity for every single one of our audits, with the exception of one, which I blame on COVID. So I'll use that as long as I can. But I was here, it was really hard. We were doing a lot of telehealth, and unfortunately, none of the telehealth services counted towards our need to be in person with folks 120 minutes a week. So that's all of our scores. So I think we do pretty darn good, if you ask me. We've been over 4, which is our goal, pretty consistently for the past 6 years. And then just a couple of last minute things that I think are unique about our Valleywise ACT services. I'm hoping the MAT treatment isn't unique, but we do provide medically assisted treatment for both opioid use disorder and alcohol use disorder for our folks that are already here on our team. We don't see anybody outside of our enrolled ACT members, but we're able to do in-office buprenorphine inductions and maintenance and naltrexone long-acting injections, which I think right now with fentanyl out there as much as it is has been incredibly helpful. One other thing that we do that I don't believe any other ACT teams are doing is the Zyprexa Relprevv, which is a long-acting injectable olanzapine, and that's really opened up our breadth of medication options for patients who really struggle with taking oral medications but don't respond to one of the other long-acting injections that are more readily available on the market. A couple of other things that are really special, I think, about Valley-Wise is that we're PCP partnered. We're a big hospital system. We have many primary care doctors and access to specialty care here. We also have the largest inpatient psychiatric hospital in all of Arizona, and also a full service medical facility. So we're able to try to keep our patients in-house for all of their medical care, which really helps folks to be able to have us sharing their medical records and be able to coordinate care on a much more easy basis. And then another unique aspect is that we're a major teaching hospital. So as Lori brought up when she was introducing me, I am on faculty at several medical schools and the core faculty of our psychiatry residency training program. And I think anytime you have an opportunity to train the future doctors of the world, it just makes you better because I have to be good enough to be able to teach them, and so do all my colleagues here. I have included references, which will give you links to all the different articles if anybody is interested in taking a look at any of that. And that is all I have. I think there's maybe a few questions in the chat. Okay. Oh, it looks like, thank you, Blythe and Vicki, for putting some links in there. And then the one question was, how often do ACT teams offload patients they're actively taking care of by determining they no longer have SMI? Wow. I believe we have done that once in 6 years, and I'm not sure that's something that happens very often to decertify somebody from not having SMI. Is that what you're asking? Or like they've just completely recovered?
No, that was the question.
Okay.
Yeah, that happened many years ago to us because our son was really difficult.
And they decertified him from SMI services.
Yeah, they were guardians and they said they didn't need us to come back. And we got a letter saying that they determined it was no longer SMI. I'm like, great news. I hope it's true, but we didn't believe it.
Yeah, wow. Wow. Well, that is not something I see happen routinely. I don't know if Blythe may have more data on that just from the Mercy Care. She's shaking her head no, so I'm going with no.
It doesn't, because there's a formal process, and I'm guessing that's why you're kind of like, oh wow, there's actually a formal process in regards to a decertification from an SMI designation that includes an evaluation. There was way back in 2014 when the system went integrated that there were some administrative decertifications, and in the sense that folks weren't looking to remain their SMI criteria and hadn't been engaged in services, but I can look on the webpage, but there's a formal process for that.
Yeah, I know the one time we've gone through it, it was not, it was a very complex process. I have a couple of other questions. Do ACT teams work with patients who still live at home with family or mostly homeless? Yes, that's often our ideal patient population, and or group homes as long as they meet criteria. So we do try to not take folks. We're very limited. Some of those other fidelity criteria that I didn't mention is we are limited at 100 patients. I can never take more than 100 patients. I can only onboard 6 per month to make sure everybody on our team is getting the care they need. So we do try when people are in residential facilities and flex care facilities, they're already getting care that is higher than the level of care we offer at ACT. So we try not to duplicate those services because it really does take away for space from other folks who are living independently or with their families that need the help. So yes, often we take people that live that are homeless or are living with family. Do you have patients on clozapine and do you ever prescribe ECT? Yes, the answer to both of those questions. I believe I have 33 of my 98 current patients on clozapine. It's very common. We treat people who have very treatment-resistant symptoms on this team. And so we do use quite a bit of clozapine, including our patient that we had the story about today, which is part of why she stays on medication observation. And do we ever prescribe ECT? Yes, I have 2 outpatient patients currently who do outpatient maintenance ECT, and that has been a mainstay of their treatment. And going back to special things that Valleywise does have a full ECT program. And so that's actually, it's complicated, but it is something that we are able to coordinate very effectively. How does ACT get reimbursed? I believe that we are reimbursed almost entirely through Mercy Care on a capitated rate per member per month. I don't know if that answers the question that you're looking for, but we do also bill for my services, particularly for the psychiatry services. If somebody has a primary commercial payer or a Medicare plan, we will bill those insurances as well. Does that answer the question for?
Yes,
Okay.
thank you.
Does your ACT team have finger prick ANC devices for clozapine? We do not. We've explored it a couple of times, and to be honest, that is not one of the major barriers for most of our patients. Most of them are really used to the blood draws and hasn't been a big issue. But we've looked into it, and it was complicated about 5 years ago because you had to use a special pharmacy. It's gotten a little easier. So I know our administrative team has looked into it, but it hasn't, to be honest, been a very big priority for me because it's really, it seems like it would be a huge barrier, but it's not actually one of the biggest barriers I deal with.
Well, thank you, Dr. Darling. I think it was a very excellent presentation that's filled with data. We'll have it zipped as a PDF and available on our website. And I'd love if you have the time to stay, you're welcome to stay.
Lori, could I ask a question of Beth and of Blythe? Many years ago, our son was on an ACT team that was really just awful. In fact, my wife was in his apartment visiting with our son, and about 15 minutes later walked out and saw a note scotch taped to the door that was from the person from the ACT team who was supposedly coming to do a check on our son. And the note said, sorry you weren't here. I'll come back another time. Well, he was there. They were both in the apartment. It was a way for that person to check a box that he had created a billable encounter. And many things like that happened, including finally they said they're going to knock him off of that ACT team because he was not engaging. And I argued that, well, isn't the purpose of an ACT team for you to be assertive and continuously reach out to the member and help them engage, and do that over and over again in different ways to get them to engage? And I guess that my question is, at what point does Mercy Care or any REBA or any regulator get enough complaints about an ACT team to go to them and say, we're simply not going to continue our relationship with you as an ACT team. We're not going to renew your contract. What does it take to get rid of some of these ACT? And we've had a great experience since, especially since we came to COPA. But what do you do about some of these ACT teams, hopefully very few, who just are terrible?
Should we hold that until after Blythe's presentation, and maybe she can talk about how at least Mercy rates their ACT teams and what they do if they have someone that's underperforming?
Sure.
Or someone with a lot of complaints. Because I think Blythe, you would probably be the best judge of that, since you see.
Sure, I
the
can talk
project.
through our contract enforcement process.
And one last one, Chuck has for, I think you, Dr. Darling, about, is it ACT or MAC? I couldn't tell whether it's a typo.
It says MAC, but we are not a MAC team. I believe COPA Health is the only agency that currently has a MAC team.
Yes.
Population that have a dual diagnosis or.
Yeah,
So-
I'm assuming that Mr. Goldstein, your question is in regards to a medical ACT team. So that is a specialty ACT team, and COPA has a specialty medically ACT team. So there's ACT teams, there's FACT teams, and there's one MAC team. So the FACT is a forensic ACT team.
Thank you.
And
Yes,
there was a question about the Zyprexa LAI or some other, yes. So we do the Zyprexa long-acting injection here on our team, and I think it works phenomenally for the patients that it's appropriate for, which is a very small number of people, but it's been extraordinarily helpful having just another tool in our toolbox.
what I'm questioning is
Sure.
to make myself
Yeah.
as clear as I can. A lot of patients with serious psychiatric conditions use drugs. So that's what I meant by
Yes.
dual diagnosis. And I was just wondering what your experience was, if any, if you're using long-acting and basically medications for their drug problem and long-acting medications for their psychiatric problem. Have you had any experience with that, and how has that worked out?
So I currently have three patients on long-acting naltrexone. 2 of them are for alcohol use disorder. 1 is for opioid use disorder. What I would say is my opioid use disorder patient did much better before fentanyl came on the scene. I think naltrexone long-acting worked much better to prevent folks from being able to feel the effects of opioids when they were using heroin and oxycodone and other less potent drugs. With fentanyl, people do seem to be able to overcome the effects of naltrexone. I do think it continues to prevent her from having an overdose, but I think that it is really unfortunate that fentanyl seems to be taking over the drug scene currently, because it is so incredibly potent and the overdose potential is very high. We do combine our naltrexone LAIs with the long-acting antipsychotic injections all the time, and it's gone very well for a number of folks.
Okay, that was my actual question.
I'd like to respond to that as well. Actually, in the ACT team, it is very ideal. For example, if we want to put patients on, MAT, medication-assisted treatment for opioid use, we use the Suboxone, and the reason is because we have the capacity to actually give the patients dose per dose and monitor the intake of that medication for the patient and lessen the risk of abusing the Suboxone. Actually, like in my team, I would have those medications put in a lockbox where, the patient, of course, consents to keep the lockbox locked until one of the ACT specialists comes in and watch them actually put it in their mouth to take. When I had a patient doing that, it actually worked very well. And it's something that, for example, in a supportive team, they can't do that because they don't have that manpower to do it, but we are able to do it. And when it comes to long-acting injections, that's almost like staple for our patients. It's very commonly used to control to help with adherence as well as control the symptoms. Yeah.
Thank you.
Okay.
There's another question. I don't know if you want me to answer it or if you want to move on.
Go ahead. The one about ACT consent.
Yes.
Okay. Go ahead.
The
Both-
question
both
is the patient's consent to an ACT required Where the patient has a guardian, do you accept the guardian's consent for admission to ACT, even if the patient expresses that he or she does not want to be involved? Does it matter in these cases that the patient is on COT? So there's a few different questions in there. Yes, the patient has to consent. ACT is a voluntary treatment. Even if you are court-ordered for treatment, you cannot be court-ordered for ACT.
Hmm.
Can a guardian consent on behalf of the patient? Yes. Does that work? Sometimes. So it's very patient dependent. I find that folks who are at least like reluctantly agreeable, we have a lot more ability to sort of get in and work with them. People who are absolutely not going to let us come in their house, not going to talk to us, it doesn't matter how many days a week for how many months, because they don't want this, we are in their way. That makes it very difficult, even if the parent consents. And that happens occasionally as well. So yes, we will take folks when the guardian consents, but we will often have a conversation with the guardian and with the patient about that and sort of see what's our in. I have plenty of people that if given the choice, they probably wouldn't be with ACT, but their guardian wants them to stay with us and they're, agreeable to do what we suggest to some extent, and then we're able to work on that and make progress over the years. But people who really absolutely do not want us in their business, it can be a difficult ride.
Thank you. Okay, so Dr. Belmonte, do you want to go ahead and share?
So let me stop sharing. There we go.
I don't have a slide presentation like Dr. Darling, and I want to thank Dr. Darling for taking up the important issues related to ACT services. I just want to, emphasize certain things. I think Dr. Darling covered a lot of the important things to know about ACT team. So I just wanted to introduce our, what COPA Health ACT teams do. We do have, we do have 5 ACT teams within COPA, 4 of which are regular ACT teams, and one of them is the medical ACT team. The difference between a medical ACT team and a regular ACT team is that in a medical ACT team, there is a primary care physician that is part of the team. And then they also have a criteria in accepting patients in that particular team. One is that they have a chronic medical condition that is not well taken care of, and because of the mental illness. So having an ACT team help them take care of their, get them stable so that their medical illness could be taken care of as well. Is kind of like the way we decide on what type of patients we would accept for the MAC team. For example, somebody who has diabetes and has blood sugar of 600, 700, because he or she is not able to really take care of the medical illness because he doesn't have the capacity to do so because of his mental illness. So having him in a team like the medical ACT team, the hope is that could be taken care of and addressed. So I'm just giving I'm just giving diabetes as one of the examples. Hypertension is another one, and then what else? Seizures, something that if we just help the patient, if we just are there to support the patient, their medical condition also could get better. So that's the reason why the MAC team came up, and that we have that particular team. And then the regular ACT team is similar to what Dr. Darling was talked about. What we have, is that we have there's 13 total of members, staff in an ACT team. The doctor, the clinical coordinator. We have 2 ACT nurses. At COPA, we have 1 ACT nurse who takes care of all the in-house needs of the patients, and then the other ACT nurse is the one that goes out in the field to do whatever is needed by the patients in the field. Like one example of that is going to, like a PCP appointment. Sometimes the patients would go to a PCP and they would not be able to explain what their problem is. Yeah, they don't have the medical term to say what's going on with them. They just say, oh, my back hurts because my bed is bad. And then also for me is, like knowing the stigma that, some, maybe not all, but some PCPs, when they say, oh, it's all mental, I don't like that. I don't like that for my patients. So I have the nurse go with them so that they could advocate for the patient, so that the appropriate medical care could be provided for the patient. And also whatever medical condition they have could be addressed appropriately. The other thing that the outside nurse would do is, like they do give injections out in the community. It could be at the corner of a parking lot or corner of a sidewalk. It doesn't matter. We'll reach out if we need to. The other, so we have those two ACT nurses, and they do more. And then we have the ILS specialists, ACT specialists, who kind of like could do all the different specialties. We have a program assistant, 2 substance abuse specialists, voc rehab, housing specialists, employment specialists, and peer support specialists. One thing to also know about our medical ACT team, just going back there, like our medical ACT team is very innovative and actually received like 3 RICE awards in the last 4 years. Being unrecognized for their work in resilience, innovation, service, and empowerment. That's why it's called the RICE Award. And then some of them are duplicates of what already Dr. Darling already talked about. But there's like some things, just core things that I teach and I would expect from my ACT staff. One is we believe in the principle of we meet the people where they're at. I'm sorry. Oh, I didn't hear it.
I think that was just someone's background noise. If they want to ask something, they can raise their hand and put it in chat, and then we'll call them in. Sorry about that.
Okay. So yeah, so one of the things that we believe in is we meet people where they're at when it comes to ACT services. And another one is that we do whatever it takes as long as it is within the bounds of the law. I always tell that to, like to my staff, like and then I expect my staff to be very flexible, to be creative, to think outside the box, because there's no one way of treating a patient. There, like if this way doesn't work, we have to go another route to reach them and to engage them. Another one is that there is no giving up as much as we can. There's no giving up because there's a reason why a person or why an individual is actually referred to the ACT team. We try what we can. We try what we can. We do as best we can. It might not happen in the first year. It might not happen in the second year. It might happen on the 10th year, but the hope is that it will happen at some point. We cannot say, oh, I can't do anything. I cannot do anything about this anymore. I can't. No, we sometimes, or most times, we are the only hope that these patients have. And that's why we're here. I'm very passionate about ACT services. I love this type of practice in psychiatry. I believe in the ACT model. It has changed lives from doing it for the last 20 years. I've seen it change lives for the patient themselves as well as for the family. So I think this is the best thing that happened in psychiatry.
Thank you. I have a question. Do you guys try to model at least good behavior as far as eating habits? It used to make me cringe when I'd see one of those large Circle K drinks full of sugared, caffeinated. I'm like, no. I mean, you can't tell them don't drink that, but you could say, you may want to try this. But
Yes, whenever it's like the connection of the patients with the ACT staff, because we've had them, like, for example, just in my team, I've had some of my patients for the past 12 years. I've seen them every month for the past 12 years, at least. My team I don't have a lot of turnover in my team. So some of them have been here for the last 12 years with me. So when we see those things like unhealthy behavior like there is one that certain patient actually responds to, one of the staff that responds to, and they actually, they're able to tell them that. And so a lot of times the patient respond, and a lot of times we kind of like keep on reminding them that this is probably not a healthy thing, and we'll direct them to something else. We accompany them sometimes to going to the grocery and finding the right food, the more healthy choices, teaching them that. That's where the ILS specialist comes in. So the independent living skills specialists come in.
Okay, there's a couple other questions. One is, what is the role of the peer support person in the team?
It's a very, very important part of the team, the peer support. So, like sometimes like those patients that Dr. Darling is talking about that are, say the guardian wants the patient to be in the ACT team, but the patient themselves are like 50-50 about it or not really engaging. That is when a peer support is really, really helpful, because they are able to talk to them at the level that the patient actually really understands, and the patient responds to them very well because they feel like, okay, you're one that walked the walk and is actually now, that have been here, done this, and so, like they really connect with them very well. And so that is one way of kind of like reaching them to engage with us. And then I also have them sometimes sit in with me during the appointment, the peer specialist, so that if, for example, I'm saying something that probably I'm not speaking the language that is understandable to the patient, the peer specialist is able to translate it for me. And it's very useful in this type of practice.
Now, another question was, do you encourage and foster client-to-client friendships? And you can answer, and if you agree, Dr. Darling, or if you have a different answer, you can also answer.
What is the question? I'm sorry, I didn't.
Do you, I assume it's the ACT team, encourage and foster client-to-client friendships?
Client friendship. Like I would just from my experience, I would just say like they are in the groups, they talk to each other, but I have not really seen like two people going out and being friends out in the community. Do I encourage it? It's still a social, it's still socialization, and we're with them anyway. If there is something that we see is not providing positive effect on the other, then we'll call them on it. I can't say that I will discourage it, or I can't say that I will really encourage it. We deal with it as they come.
And there's another question. Does the ACT team visit patients in the hospital? That's one. Can the ACT team also help support mobile dentistry appointments?
The first question, can the ACT team go to? Yes, I myself do hospital visits. If I want to onboard the patient, if the patient needs to be onboarded already so that we could start engaging while the patient is in the hospital, I would go to the hospital and start seeing the patient there so that by the time they come out, they are already, like they're already with the ACT team. And then I would have my staff also go and see them. Once I start seeing them, they start seeing them. And then what's the second question again?
Can the ACT teams help support
Mobile
mobile dentistry?
Yes. Yes. Like I said, in what I said earlier, whatever it takes to get them healthy, mentally, physically, as a whole person. One of the roles that my nurses would do is make those appointments, ensure that they get to the appointment. Sometimes would remind, those who makes arrangements for transportation to ensure that happens at the time that is needed.
Thank you. Two others, and then we'll go on to Blythe and then ask at the end other questions. But have you ever considered animal therapy? One. And then we have one about the on-call ACT team.
Animal therapy. Yes, one of my ACT specialists before would take our patients, our members to horse therapy. She will have them come to the clinic, and then they all go to or we will have the cabs bring them to that particular place to do horse therapy. Is the on-call ACT member empowered to amend patients to the hospital? We have had issues, crisis situation happening after hours.
Isn't ACT on call 24/7? So
Yes.
you could call them after hours and say, this is going on. So
yes, we could definitely, well, I'll just give a scenario. If a patient has a crisis and it's after hours, somebody will call 911, or like outside of the team, somebody will call 911, and that 911 or crisis call will direct it to the ACT team. And then we'll see if it's even possible to de-escalate the patient, or the CC, the clinical coordinator, will mobilize at least two of our team staff and check on the patient, see what's going on. And it doesn't matter what time of the day or what time of the night. And then if it needs an amendment, then or petition, then we'll do that, because the patient is a danger to self or others. Or sometimes we're able to de-escalate the patient and we prevent that hospitalization. It really depends.
Okay, and her question is again, can the on-call team, if they see behaviors or a situation, can they themselves that evening, off business hours, put an amendment in to get them back to the hospital?
Yes. The simple answer is yes, they can.
Okay, thank you. So thanks both to both Dr. Darling and Dr. Del Monte. And now Blythe is going to speak from the perspective of Maricopa Zariba, one of the biggest for people with serious mental illness.
So good evening, everybody. I have a deck, so every system is different. So let me see if I can share screen. Okay, let me see here.
Okay,
Okay.
we're seeing it. Thank you.
Okay,
Glenn.
great. So some of the information I'm going to have and I want to speak to. So for Mercy Care, this is for the central region. So Maricopa County, and then as of October, Pinal and Gila. Oop. Now my screen won't. Oh. What am I? Sorry, I'm having some technical difficulties. I don't want to sign the PowerPoint. Can you still see it?
Yeah.
Okay.
So just hit that. I'd hit
All
that
right.
close.
Because I can just see you're sharing a screen. So you should see a screen that says what is ACT. Is that what you'll see?
Correct.
Okay. So some of this has already been earlier discussed. So what is ACT? So Assertive Community Treatment. It's a member-centric recovery-oriented mental health delivery model that uses an interdisciplinary team. So this was talked about. It is an evidence-based practice that has been shown to have very positive outcomes. It's designed to provide comprehensive community-based psychiatric treatment, rehabilitation, and support to persons with a serious and persistent mental illness. As shared by the earlier presenters, it's member-centric, recovery-oriented, community-based, in-house model, and team approach. So it's meeting the person where they're at. Who does ACT assist? So some of this, Dr. Darling had talked about the criteria. There's been, typically with any evidence-based practice, there's been a wealth of research that has been conducted in order to determine its evidence that it's a best practice. So it is designed to assist individuals with serious persistent mental illness, severe functional impairments, with the caveat, as mentioned by Dr. Darling, in regards to considerations for folks that have a primary personality disorder and or folks that have a primary developmental disability given the symptomology. It's designed for folks that have coexisting situations. So maybe they're experiencing homelessness, maybe they have substance use challenges, co-occurring involvement in the judicial system, and that gets quite a bit on the specialty side also to forensic ACT teams. Tailored services. So I feel like I'm repeating this, but this is kind of the SAMHSA evidence-based practice. So it's designed to be tailored. They're supposed to be individually based, that are designed based on the individual needs, and to meet the needs of the individual, not the team. So it is a team intervention. That's why a lot of times when we think of assertive community treatment, it's not case management, it's actually an intervention in and of itself. The approach with each member emphasizes relationship building, active involvement, and helping members with severe and persistent mental illness. And this really gets to, I think, the engagement and the benefit of having a team of folks that are consistently working with somebody, meeting them where they're at, building relationships, versus kind of getting different referrals, having to go various places, because the team approach can really help with the engagement. Here's just a little bit on the comparing service models. So sometimes you get this. So as we talk about case management, so case management, covered service. If you are an adult with a severe mental illness designation in Maricopa County within the health homes, you would get an assigned case manager. So case management, you have caseloads of 30 members or more. Those are based on caseload requirements. For assertive community treatment, it's staff to member ratio about 1 to 10. Services are brokered from other providers, and what is meant by brokered is they're referred out to another provider. It's not provided by that team. ACT is meant to be delivered as a comprehensive, all-inclusive service delivery. So as has been talked about in the earlier presentations, that's why you have the various specialties. So individuals within that team that can come together and provide those services to the individual as identified. Case manager is solely responsible for the member assigned, and what that means is the brokering. So when we talk about a case manager, they help do the coordination of services. They might get referrals, they see a doctor, they see a nurse. But in the sense of an ACT team, the whole team is responsible for caring for the individual. The change in intensity of services can mean a change in providers. So this is one thing at Mercy Care that since 2014 that we've continued to kind of look at the network. I know Dr. Darling talked about this, and COPA has the same, which is the ability for one provider to offer different degrees of services so that it doesn't necessarily mean that an individual has to change a provider. But the ACT services, what we're really getting at is type and intensity are easily varied. So there's lots of structure within the ACT team. So team meetings, talking about status, case coordination, and working together as a team to determine. Did somebody have a question? Or was that just feedback? Oh, I think it was just feedback. Somebody might have accidentally hit their butt. So it could be, dated like twice a day visits to maybe then it's shifting to 3 times a week, or then maybe it goes back to day to day. So that's really what that's getting at, is the ongoing understanding of what that person would need, and then the team coming around to adjust the contact. The members get the services they need if the service exists and meet eligibility. So this sometimes can get in the sense of like that referral process. And that varies in different things. So on an ACT team, again, that's all inclusive. They're just talking within that team and working together to determine what that person would need. The concept that members might be dropped from a caseload, non-compliant, jailed, or getting services otherwise. What can happen with that is, for example, is maybe somebody, they transfer to another clinic, or maybe they're going to get services somewhere else. Again, versus the ACT services where they're getting all the services there. I think Dr. Darling spoke to this and articulated like the transition process. It's a transition. It's not just we're going to stop this or something happens within that. And then here in the sense, like you could get moved from a different case management or you get transferred to somebody else. The ACT team remains the same. I mean, ACT teams will change, but their team remains the same. These are the 5 core services. So this gets to the fidelity reviews, which is psychiatric services, counseling, psychotherapy, substance use treatment, rehab and employment services, and then housing support. So again, it gets to the specialty positions that are part of the fidelity reviews in identifying the specialty positions and the services that they're rendering based on identified clinical needs. This has been talked about. I know this has been a question. So members go through a screening process. So Dr. Darling shared that. That is something that we developed that matches the SAMHSA protocol. ACT is voluntary. Members do have the right to decline services based on member choice. Guardians can consent for ACT outpatient level of care as allowed by their guardianship rights. But that engagement, I think, was, as Dr. Darling stated, clearly articulates kind of the balance of that and the conversation. But a guardian can consent to ACT. The way that ACT referrals work, so any health home for somebody that's providing case management services can refer to ACT. You can do an ACT to ACT team transfer. We also work to make sure that folks that, because frequent hospitalization is one of the criteria that somebody may benefit from an ACT team. So we also do support hospital referrals from level 1s and emergency departments. We also want to make sure that if somebody is newly determined SMI and they may benefit from an ACT team, that they're not having to go through that process of getting on a supportive team when we know out the gate that ACT might be clinically appropriate. So we facilitate Stellari crisis and human service referrals. And then our forensic ACT team process is different in the sense that we have justice folks engaged on that to be able to speak to criminal recidivity and making sure that we're partnering very closely with our justice partners for folks that are getting referred to the forensic ACT teams. So fidelity. All of the assertive community treatment teams get a fidelity review. It's evidence-based. It focuses really on the program components and how are the teams doing those. They are individually scored with a total summary scoring of that. And on the next page, we actually have, oh, it's the following one, but it's actually, you can see all of our contracted ACT teams, what their fidelity scores are. And then each team is scored annually. Access in which he made some changes based on the scores of the ACT team, their ability to get re-reviewed. And then with each score, there is a whole process that occurs in the sense of talking about those scores, looking to see what are the areas for improvement. And then in partnership, another thing that we do is annually, we work in connection with Access and WICHE to do larger technical assistance for any overarching system trends. The other thing that kind of comes in, I know this was a question that gets to, so fidelity is one component of that. And then should we have concerns, as we would with any other kind of standards or expectations from a contract, we have a formal contract informant process that actually goes through a process improvement process so that providers get formal notice of the area of concern. We request that they submit to us a plan of correction, and that can go all the way up to either sanctions to contract termination. The fidelity tools, so again, this is done by WICHE, so it is a separate party. This actually came into effect in 2014 when Mercy Care came on in the REBA and the Arnold exit, that a third party would do the fidelity reviews. So all of those fidelity reviews are done by WICHE, Webster Institute of, what is it, Higher Education. And they post all of those. It's all public knowledge. And then there is an annual report that also summarizes all of the fidelity reviews, which is part of the annual Arnold oversight requirements, such as Mercer network capacity and the QSR. So some of the things that we've put in here kind of to, I'm rambling a little bit, but I don't want to duplicate the information that has already been shared. But we also work closely. So for example, a team gets a fidelity score. We'd also work closely with our provider monitoring and WICHE, and if need be, would ask them to actually implement a performance improvement around that. So how are they going to move some of those scores up? What are they actually going to do to drive on the fidelity standards? This is a little bit about WICHE. So I think the main thing here that you're probably is really getting to this annual biannual reviews. These are also based on the team's performance. Again, the benchmark is we're looking for a score of 4 or higher. They are publicly reported, so that is posted up by Access. The link is in here, and I think Vicki Staples shared that link earlier. So everybody has access to look at how the various teams are performing. And that also includes other evidence-based practices that are implemented under Arnold. So total, there are 24 ACT teams in Maricopa County. 21 have primary care provider partnerships. And what we mean by this is in the light of integrated care, we wanted to make sure that ACT teams were partnering with a physical health provider to provide comprehensive services. And then we do have the 4 specialty teams. So one is the medical ACT team. And that was, as Copa mentioned, so there are specific criteria to qualify for a medical ACT team. And then there are 3 forensic ACT teams. So there's a forensic component related to that. And then lastly, as part of our expansion in the Pinal County, there is 1 ACT team there with a PCP partnership. And so they are also held to fidelity reviews as well. And then if there's any specific questions, so we do have an email for ACT referrals at mercycarearizona.org. So Noemi, she's our ACT manager, and she works directly with the ACT referrals on that. And I see there's some chats questions, but I can't see the chat when I'm sharing. So let me stop sharing.
I can read some of them to you. One is the forensic ACT team involved when the individual is incarcerated or just upon release if necessary.
They can get involved at the time when they're actually incarcerated. So there can be time when we call it like a ghost caseload. So basically they're engaging with folks that are actually incarcerated to help with their transition.
But those are people intended to be released, or are they people before they're sentenced, or does it matter?
It would be when they were discussions of release. So not upon incarceration, depending on the time, because the intent of getting engaged in the Forensics ACT team is in order for them to be able to help support them in the community. So if they were just at the point of sentencing, and let's say maybe they might be incarcerated for a year or longer, then we would want to be able to get them engaged when they're getting close to their release. Because as far as the ability for the forensic team to provide interventions when they're actually incarcerated without a release date is limited.
Thank you. I think there was another question. It's probably for the providers on.
Yeah, I'm going to need a,
Yeah.
I have
lifeline?
a PhD, but it's a book PhD. So I am not even gonna try to touch in regards to the medical question in regards to major depressive disorder. So if one of my the other counterparts want to take that.
So very good question. There are a couple parts of this question. First, we have very few MDD patients on ACT teams. It's not typically a diagnosis that leads to ACT referral very often. I think I've had less than 5 in the 6 years I've been running this team. The second part of the answer to that question is esketamine is difficult. It's a REMS monitored drug, so it's a difficult drug to implement or to provide. You have to have trained staff, trained nurses, doctors. You have to be registered, and there has to be a monitoring program with the esketamine. So I imagine for how little we would use it based on the number of patients I have, that would be appropriate for it. It's probably not worth Valleywise's effort that it would take for us to be certified. And also, I don't believe the coverage is very good for most insurance companies. So a few reasons why it probably wouldn't be my go-to drug.
Thank you. Any other questions to any of our presenters? If not, we'll go to some stakeholder discussions. And I invite you, oh, Evelyn has her hand raised, but I invite you when we go to the stakeholders, even I'll ask people to respectively not ask for specific information on their loved ones. They can ask in general, they can talk about a horrible situation, and then in general, they can respond by saying, typically when we see this, but this is a public meeting, so therefore they're not going to provide specifics. They may give you a number to call to follow up, but I just want to be respectful of our presenters and be kind. So Evelyn?
Oh, okay. I started trying to type this in the chat, then I figured I just say it. So I'm wondering, is there any review process to ensure that when an ACT team client calls 911, that it actually gets relayed to the ACT team? Because, you know, our family had a situation where it did not happen and the ACT team, you know, didn't know what had happened to the client initially.
So to my knowledge, there's no direct connection between 911 and behavioral health providers. So there is the 911 diversion program that happens through Solari if 911 calls get diverted. So that would be a point of like discussion and care communication, because there's no feed between 911 and a provider.
Oh, so it was only if they call the crisis number that they get referred to their ACT team?
The crazy, and I see Dr. Darling shaking her head and others on the day-to-day direction. So if they call the crisis team, of course, like the crisis service, they have the ACT on call, so they can do that. But I want to stress, and you know, Copa and Valley Wise, please jump in here. But, and I think Lori said this as well, should somebody be on an ACT team and they need assistance, they can call the ACT on call. They don't have to have the crisis team call them. They can be calling crisis and, you know, contacting the ACT on call to get that assistance. So it doesn't have to be one or the other.
Yes, that's correct. As soon as somebody is onboarded on our team, they are provided with both our on-call and our backup on-call phone numbers, and they have free access to use those numbers as they need to. If somebody does call the county crisis line instead, I would say the very large majority of the time they're able to pull up their roster and see that they're on an ACT team, and they will connect the call to our on-call folks. With 911, it's definitely a little, they don't have access to that information. So unless crisis were to get involved, they wouldn't have any way of knowing that unless the patient said to them, I'm on this ACT team, this is their phone number, and it helped make that connection.
Well, thank you guys. So I think, I mean, you're welcome to stay and you're not obligated to respond unless you want to, but I think it's always interesting to hear about some of the current challenges either families or families of loved ones are going through that have really these difficult diseases to treat.
And
So
I apologize, this is why I have to drop. I actually thought we were done at like a little after 5. So I have been texting somebody. I was like, I will be there shortly. So I apologize. Thanks for having me. The information's there. I know many of you have my email address as well. So I'm happy to assist where I can.
Thank you, Blythe.
Thanks,
I
Joelle.
also have to step out, but thanks for inviting me. I'm always happy to share about our ACT team. I'm really proud of the work we do here, and it's fun to talk about it. So thanks for the invite.
Thank you. It's a great presentation. Lots of information.
Bye.
Thank you. So I will stop the recording now because we don't want to record